So it's a very, very great pleasure today to welcome Professor Nicolas Othieno-Abinya from Nairobi in Kenya, an internationally recognized hematologist and this year's winner of the ICML F Prize for his work in improving CML care in low and middle income countries across Africa. It's a privilege to share this platform with you today. And thank you, Professor, and welcome, Nicolas. And our international expert, who was very active in the chat yet. So this is, I think I don't need to introduce you to the CML community a lot, Professor Mike Mauro from the New York City Memorial Sloan Kettering Cancer Center. And he's also professor at Weill Cornell Medicine, director of the ICMLF, and all around a great friend of the organization. So welcome, Mike. Wonderful to have you here with us. And I'm now very much looking forward to listen to your two cases, Nicolas, and to discuss it together. Welcome.
Thank you very much. Good evening. Now, mine is pregnancy in CML, case 1. Now, I have no disclosures. Just background that current therapies of CML, as we are seeing, emerged from Brian Drucker's presentation at ASCO in New Orleans. At least that's when I first heard it, of STI 571, which gave really after which the current tyrosine kinase inhibitor therapies were developed. And soon after that, the foundation, the Marx Foundation, that had been started in 1996 by Pat Garcia and team, then introduced the first tyrosine kinase inhibitor, BCR-ABL, and that was imatinib. And we used this agent until, as indicated, second and third generation medications came in. Nilotinib is available to us on sale, and asciminib we get, but the rest have been available free. And when we talk about pregnancy in CML, we are talking about use of these drugs in chronic myeloid leukemia. But we know from the beginning and from the history of cancer therapy that there will be toxicities by these agents in pregnancy. And as shown there, we know that those toxicities to the fetus in particular do arise. And so right from the first day, one avoided using these drugs in women who are expectant. So the kind of discussion we are going to have is more on the mother rather than on the fetus, because we have avoided this in entirety. From 2004, we have treated 3,235 patients on the program, 90% of them being chronic myeloid leukemia, and about 1,300 of them being women. 19 pregnancies have been registered, and there have been 4 maternal deaths, not immediately, but as a complication of delays of treatment because of pregnancy. SNK and first patient that we are a primary school teacher, married to a fellow teacher, no smoke, no drink, no family history of cancer with no significant past medical history, came into the program already para 3+0, and seen in our facility on the 21st of May 2012. Physical examination was typical of CML. Hepatosplenomegaly, as shown there. Bone marrow was compatible with that of CML. BCR-ABL was positive at 91%. And on 23rd of May 2012, we started on imatinib at a dose of 400 milligrams. And the HB at that time was low. Within 3 weeks of starting that, she reported missing her periods. And we discovered that at the time we were starting treatment, she actually was just about conceiving. It was difficult to get that fact clear. On review on the 16th of August 2012, the size of the spleen was as given, the white cells high, HB down platelets were high at 1200. She delivered in between. The date of delivery did not come out clear because consistency in attending clinics was not very good. And so in October 2013, after she delivered uneventfully, and the baby the child now is alive and well, but we started having problems with the dose of imatinib. So we had to raise it. At that time, we did not have second generation TKI. So we went up to the dose of 800 milligrams that was recommended at that time. And this did control her counts. And by May 2016, the dose was stepped down. And she was doing well, but because of inconsistencies in attending clinic and not actually adhering to tests, not even to the BCR-ABL, we could not monitor her properly. And by February 2018, we could notice that treatment was failing. COVID came in, and then by February 2020, platelets have dropped to 60, and we knew we were facing trouble. And by July 2019, treatment was still failing. We ordered BCR-ABL, but it was not done. And in March 2022, for some reason, after the COVID vaccine that she received, she started having more symptoms and skipping her menses. And we switched her to dasatinib at that stage, but this did not hold it. These are the blood parameters, which we are not going to go through, just to show that initially she appeared to have progressed quite well in between, but then later on this started going down. And as you can see at the bottom, the red ones, by September 2021, everything crashed. And by May 2022, she was reported to have passed on at a national referral teaching hospital. Now, the conclusion that we drew from this is that, one, this was an educated family, both teachers, but from a community where pregnancy is given high priority. She appears to have conceived the same week that imatinib was commenced. The first 3 weeks on imatinib was actually when she had just conceived. The child, as we inquired, is reported to be in good health and is attending school. Non-compliance was a major issue, though she held on for more than 10 years. But the last 2 years were shrouded in transition to high risk, and by the time we lost contact with her, she was in blastic phase and went and passed on at another hospital. Now, not too many questions on this. The question that one wants to ask, in this patient A, who was not compliant with clinic, with the tests, with medication, what is it that one could have done better? Pregnancy that was acquired in the first weeks of starting imatinib were difficult to detect. And so that ends the presentation. Thank you very much.
Thank you very much, Nicolas, for this very interesting case. And I would directly give it to you, over to you, Michael, for comments and your expert advice on this case.
Yeah, Nicolas, that's a very unfortunate case, of course. You know, as you hear this story unfold, I think it actually highlights common themes that really all patients can face, but and also are highlighted in pregnancy. The unfortunate reality was that there was a plan to start a family or to grow a family right at the time of CML diagnosis. So there's a conflict. I can tell you that in my New York City clinic, the conflict in pregnancy and CML treatment is just as strong as it may be in Nairobi or anywhere in the world. and I try to acknowledge and support that, very strongly, but it's difficult. The second point I think that this raises is when someone is diagnosed with CML, they need time to process and learn about what the process may look like. So this conflict of being started on treatment right at the time of conception, that might have been challenging to understand. I think most women anywhere in the world, even at a basic level, would say, I shouldn't be taking cancer therapy or chemotherapy if I'm trying to have a child. And that desire to carry a child may overwhelm the adherence to treatment, testing, clinic visits, and so on. The third, or maybe an additional point, would be the struggle of young families and distraction from work, from childcare, from resources, where a young mother might be not able to or challenged to be getting the care. And of course, adherence and to medication. That's a global issue. Not checking in for clinic visits. I have patients, again, right here in New York City. I have a gentleman who nearly transformed a blast crisis, having inadvertently stopped his treatment due to depression 3 times now. I lose track of him despite all of the tools I have at my disposal. So I think these are really common themes. The global CML community has tried to help us educate. What do we do when we have a woman diagnosed with CML who is pregnant or quickly becomes pregnant? That's very difficult. It is going to likely have greater likelihood of progression, and I think that's might have been what happened here. I think the education piece, I think we covered nicely in talking to patients in the last part of the first half this morning or this afternoon about engaging with patients and trying to increase their understanding of their disease, their timing of things like stopping or asking to stop for pregnancy, managing side effects. These are really all important issues, but. And then lastly, you covered a lot of the good basics that TKIs in pregnancy are a very challenging mix. I think we have the most information probably with imatinib, and potentially secondly with nilotinib in limited fashion. Dasatinib is particularly challenging in that it likely causes much more severe birth defects and can be very deleterious to a developing fetus, should not be given. And we have very limited data on all the subsequent TKIs, up and including asciminib, our newest drug, where we really have no data. So we have definitely a challenge in front of us when it comes to managing the divergent goals of being a mother, growing a family, especially in certain societies where pressures and expectations are high with CML treatment.
Thank you very much. Are there any other questions on this topic? I'm pretty sure this is something that all the clinicians, whether in Africa or in other parts of the world, encounter, including also us here in Moshi, Tanzania. If we have patients who wants to become pregnant and are still under imatinib, maybe until we are waiting for some people to type in into the chat, Michael, I would be like, I know the data are very, very rare. We cannot really predict what's going to happen, but definitely you would say like a discontinuation of probably an unknown molecular remission status would be a very, very high risk for the mother. And you would always recommend not to continue with pregnancy, or is that something you would always weigh against probably also not extremely high risk of any birth defect coming from continuing imatinib under pregnancy? If that makes sense, what I'm saying.
I think you're asking the question about how do you manage the concomitant pregnancy with CML present together, not in a woman who's not in remission, and as I was saying,
or unknown remission.
Or unknown remission,
yeah.
Exactly.
Mm-hmm.
Indeed, the risk is high. I think again, I believe with registry data and the publications available, I know there are cases of children born to women who had imatinib exposure for a significant part of pregnancy. I think many providers do weigh the risk benefits of re-exposure or introduction of imatinib very late in pregnancy, in the third trimester or towards the end of the third trimester, in order to salvage, risk of or minimizing risk of progression. in a pregnant woman. I've done that. Although I must say it's not sanctioned or labeled. But all the drugs are, as the regulatory authorities in the U.S. call, pregnancy category D, where the risk needs to the mother needs to outweigh the risk to the baby. But maybe if we can pivot, I think another point to make would be that ideally, if we can educate and ally with our patients, we have this opportunity to treat women into good remissions where risk of carrying a child may not be so substantial. And of course, I do have a lot of effort around how to maintain treatment while still trying to conceive. And now that's in my neck of the woods where we have technology. Women have easy access to, for example, urine and blood pregnancy tests, and have the luxury of being able to know for their fertility, their cycles, and all. But so that's a possibility, but it's not easy, and I wouldn't recommend necessarily continuing a TKI if someone had conceived, because the first trimester and the early exposure to a fetus is probably the most difficult and the most likely to cause challenges. Last but not least, if a woman can be treated into a deeper remission and be eligible for treatment-free remission, now we can marry the agendas of our CML treatment algorithms with the goal of pregnancy, and they may not always align. It may not be that a woman is eligible for cessation, stops, is successful, then can become pregnant. That's sort of a bit of a fairy tale type ending. I know that it's possible, but it's not. It's 50% chance of not happening generally if you think about the data with treatment-free remission. So we have to have contingencies. But that's a much safer situation where a woman may be eligible for eligible for treatment cessation or in a deep remission, and then they decide to conceive, and we may be, and that's my most experiences there, because I try to align with my patients and move them into that algorithm. So, and I see Oliver, I don't want to do your job. I'm seeing Daniela's comment about interferon, and I would be remiss if I didn't mention that one of the biggest tools that we would use, or I would recommend using during pregnancy, whether it's early or mid or late, although it's a bit of data concerned about using it very early in pregnancy for increased risk of spontaneous abortion, but interferon can be safely used in pregnancy. It may be slow in onset, it may be limited in its efficacy, but it certainly was our best treatment for CML prior to TKI, aside from hydroxyurea, and is certainly out there.
In our part of the world, is limited by cost. You may want to use interferon, but the patients may not afford it. And the toxicity of interferon is also something that I don't think terribly many people would tolerate throughout their pregnancy. The side effects, the fevers, the flus, the discomforts of this world sometimes just push them off.
And Nicolas, I think we're seeing a pretty overwhelming feedback from our colleagues that interferon may not be available in many places where we're saying it could be, and also it might be unreliable, for example. So that may not be a good solution.
But in case, let's assume we have it available, because I know, and somebody also said it's not available in Tanzania, which is true. You don't get it at the pharmacy easily, but you also know that we are always in the position to import on an individual base. If the patient can afford, of course, that is the basis of it, but we can always import all kind of individual medications into Tanzania. The same is true for interferon, but let's look into interferon in pregnancy. What is your experience there, Michael, or also Daniela? Is it very good to handle, or as Nicolas said, is it very, very hard to steer the patients through pregnancy plus interferon?
So if I can very briefly comment, so I have, to be honest, very limited experience, because as Mike mentioned, my majority of my patients who would like to be pregnant are already in DMR or in MMR, so we can manage pregnancy quite safely with just drug discontinuation. Now we know that that the patients can stay on TKIs until the first positive pregnancy test, which is quite helpful. So we are doing it, and then we stop treatment, and then we have two cases when we had to reinitiate imatinib after 17th week of gestation. So it was like for third trimester, 2 cases, but otherwise we had probably 1 patient on Pegasus, but for very short time. So regarding the adverse events, it was not the case, because it was very limited time, and it was pegylated interferon, which is much better tolerated.
Thank you very much. Before we move to the second case, Professor Nicolas, there is one question here in the chat. When do you think of resuming TKIs in a pregnancy? Like after the first trimester, for instance, or what is your safe range where you would re-induce TKI, Michael?
Oh, if I think we can each comment, but I think I've conferred with obstetrics gynecologists on this, and I think, with lung development and organ development and risk, I think the third trimester is a pretty clear window when organ development is complete, and that's when I've felt comfortable, if needed, if the mom needed it, is to use imatinib. And I think, again, there are some who would advocate that nilotinib in the registries and the aggregate data may not be as likely to cause fetal harm in that setting too. So that would be my answer.
Okay, thank you very much for your very clear answer on that. And I also see Daniela is agreeing with third trimester. Thank you very much. So let's jump into the last case for this evening. Nicolas, please.
So thank you very much once more. This is just, again, a little profile of the patients who have been pregnant on a treatment for CML in our center. So I am going to present a case of, this single business woman, resident not too far away from the capital city, Nairobi, HIV negative, para 1+0 by the time she entered the program. 15th of March 25, well, that is not 25, that is 2019, sorry. Bone marrow biopsy suggested chronic phase CML. BCR ABU was positive at 29%. Earlier. So on the 3rd of April 2017, we reviewed her at our center with a diagnosis of CML. And on physical examination, the only positive physical finding again was that of a hepatosplenomegaly as shown. Not massive, but significant. And so on the 18th of March 2017, we started on imatinib, 400 milligrams per day. And this is a patient who is a significant member of the patient support group who understands the treatment and the risks very well. So she took her medicines very seriously and was quite compliant, did her BCR-ABU tests when she could. But in February 2020, we actually noted that she was in deep molecular remission. In March 2023, on the 10th of March, she actually walked into my office and said she had been monitoring her BCR-ABU because she intended to become pregnant, and that now that she was in deep molecular remission, she had decided to be pregnant, and she was about 3-4 weeks expecting. So we stopped the medication. And she was off medicine by the 5th month. She was quite okay. Her expected date of delivery as given there, and she delivered in December 2023. No problem with the blood counts, no problem with the BCR-ABU, and she breastfed for a long time. March 24, she was still breastfeeding. June 24, breastfeeding, and last week, 25th of October, she was well, still breastfeeding. Then we ordered, the blood counts are perfect. We ordered PCR. I have not seen the results, but at this stage, I decided that while I waited for the BCR, I restarted her on imatinib, and that is going to be a point of discussion. Should I or should I not have started her on imatinib based on the blood counts alone, which were very good. Clinically, she's quite okay. The baby is well. And this is just giving us the times when there was a little abnormality on blood counts. Otherwise, she was fine. As you can see from all these parameters were very good. And so she is well. The serial BCR rebels were well. The last one I have not seen, but the conclusion that she was aware, fully aware of pregnancy risks. She took all the precautions. When she decided that it was now time to be pregnant, she was in DMR. The pregnancy was uneventful. The peripheral blood picture remains unperturbed 24 months after the discontinuation of treatment, and I'm waiting for the last BCR-ABL results. The question I'm asking is, could this be a candidate, have been a candidate for TFR? We just completed the TFR study, which is under review for publication. Was it right to restart imatinib on this patient? The mother is well, the child is well. Those are the questions that I would want to ask the panel before we close.
Thank you very much, Nicolas. You ended with a very, very clear question. So I just hand over to you, Michael.
I referred to this as maybe as a best case scenario, a fairy tale ending, which I'm glad we can end on a happy note in this conference. But that is a great case, and I think the two questions would be candidate for TFR and can we stop therapy. The question about candidacy for TFR is exactly what I was talking about earlier, that potentially if we can counsel a woman to continue treatment to achieve a deep molecular response, and potentially to look at them in sync, meaning that at the time someone is eligible for TFR, they could potentially achieve pregnancy and move on to conceive, be monitored as if they were in treatment-free remission. Excuse me. And they can then have sort of both things happening at the same time. The reality is that that's very complicated, for a woman to be undergoing the stressors of conceiving and pregnancy and all the things involved in that, while simultaneously having the stress, if you will, and the monitoring requirements of treatment-free remission, I think is a lot. But I've done it many times. So I think that's an interesting thought. The absolute best case scenario for me, which it's been rare for me, is that I have had a woman eligible for treatment-free remission who we then treat, or monitor off treatment, say for at least 6 months or 6 to 12 months, at which point the risk of treatment-free remission now is such that relapse is unlikely, and then we go ahead and conceive. That's the absolute best case scenario in my mind. But again, I don't mandate that. That would be challenging for many. So it's often more a dual agenda. The question about restarting imatinib is interesting. I think I'm conservative. So if I had someone who I was unclear of their status, or I wasn't sure, and they were doing well, and they tolerated imatinib, and they had a very good quality remission, it may be reasonable to restart until you know the situation, and then discuss with the patient and unpack that with them and say, is this something you wish to do? I always leave treatment-free remission to the patient, as opposed to a decision that we take as a provider, because some patients don't feel comfortable with treatment-free remission. If they have continued access to imatinib or other TKIs, they may wish to continue. Many would not, but I would restart in a conservative stance, monitor, and then reopen the discussion. I try to be particularly sensitive, and I have a sense in my patient population that young parents or young people who wish to become parents have a slightly different view of treatment-free remission than older adults, with regards to their life expectancy, their risks, and what they're saying when they engage in TFR. They view the risks differently, that perhaps gambling with what is a very stable situation for any risk, even though we can reassure them that TFR risk should be minimal to none. It weighs differently in the minds, I think, of younger patients or new parents or those wishing to be parents. So I'd love to hear other people's comments as well. And before I forget, I'd like to also just thank the ICMLF and everyone on the call for joining and allowing me to join this fantastic conversation.
Thank you very much for your fantastic input this evening, and that you share your experience and your knowledge. Do we have other comments or questions to the second case?
Maybe if I can just add to my comment, like speaking and thinking about TFR more in general, I totally agree. And we also did some research or survey on patients who were reluctant to participate in our discontinuation trial. So we know that it was almost one fourth of them who were refusing participation. We also had some multivariate analysis. It was showed that patients who were less educated, who were disabled, unemployed, retired, they were more reluctant to be part of this, and especially like the logistical factor, like duration of the journey to hematological center, which is particularly important in such large countries. And so I totally agree. It's always up on discussion, and patient must be comfortable with this kind of decision, and sometimes it is not treatment discontinuation at all. And I would like also thank for invitation and for this great discussion. It's really it impressed me, and I'm very glad that I was able to join, and thank you.
Thank you so much to both of you. I'm not yet to release you, the international experts. We might still have one or two questions and a couple of minutes yet, but that was so far very great.
Nicolas,
yeah, Michael, please.
Nicolas, can you answer your own questions? What do you think? In retrospect, this was your case or someone you were familiar with. How did you feel about restarting, or how did you feel about the case? Because it was a great one.
Yeah, I think I should not have started, because I had sent for the test. She was going to do it. It wasn't going to take more than 2 weeks before I get the results, and so that I would then decide if at all she was still in MR 4.5 or even 4. I should just observe her, and that's what I think. This kind of move also saves on resources. So, yeah. But now that I have restarted, when the results come back, and I don't know what I'll do with them, particularly when they're still 4 or 4.5.
Yeah, I have the luxury of PCR that I have back in, maybe 7 to 10 days, and a patient I can easily facilitate medication on and off. So I understand, but
I would say that, Nicolas, don't be too hard on yourself. It's better to be safe than sorry. So
Yeah,
I'm
that's
sure
also true.
the patient will be very happy to know that he doesn't need to take it again.
She's happy either way. She said, well, if you want to restart, you can. If you want to hold, you can. I have no problem. Either way, yeah.
Dr.
Talking
Banner
about
Dr. Banner wants to She's viewing it as yet another wave of good news. The baby's come and is healthy, and now you can stop your medication again. You know, if you even if you restarted it temporarily. But I think there's no right answer here, and but it's a great example of marrying the agenda of treatment-free remission and pregnancy together.
Thank you.
Yeah. Very, very good. And I just wanted to bring one aspect, Nicolas, you mentioned it, you know, saving resources is true, but sometimes from the patient view, if they get the medication through Max Aid, they get it for free, but then if they are on treatment-free remission, they have to pay for their molecular response monitoring. So it's a shift of resources from the NGO to the patient then. So that causes also sometimes a big problem while patients maybe decide to stay on treatment.
Thank you.
I guess yeah, sorry, Nicolas.
Yeah, I get your case, but in the first 2 years, they actually get monitoring free.
Oh, wow. That's good.
Yep.
Yeah, Oliver, I've been thinking about breastfeeding and when to start. I know lots of research in the area. It would be good to hear from other aspects, breastfeeding and when to start imatinib or TKI. Thank you.
Thank you for this question. Can I relate this question to our experts?
So I'm asking about TKI and breastfeeding. What's the compatibility? Yeah, I think breastfeeding is another one of those areas where I'll give a side story. That I was counseling a new mother yesterday in my clinic about interferon, and if you look in the literature, interferon, pegylated interferon, which we haven't used, is probably passed into breast milk, but then the baby ingests it, and oral interferon really doesn't have any effect. So most people assume it's fine. So there's a new form of interferon called ropeg interferon, and if you look, there's stark warnings about women should not take it at all if they're nursing, and I think sometimes we're lacking data, whereas sometimes practicality. So I think what we know about TKIs is that the TKIs may pass into the breast milk, but they're at levels that are subtherapeutic. And I would say so now we have a different story because it's an oral ingestion of an active drug or metabolite. So there are guidance to avoid breastfeeding with full strength administration of TKIs, but practically speaking, to a healthy person, a healthy child, subtherapeutic levels of amandine may not be life-threatening or dangerous. So I think it's a judgment call. I don't know if others have other data or other views on this, but I'm always conflicted by the data because I think practically with TKIs there's probably not as much concern as there should be, but there's warnings, and I think interferon we have a little bit of the same challenge.
I would not recommend to breastfeed and take TKIs. So I think it should be avoided. Yeah, in all TKIs,
I mean, Danielle,
what we
Go
do
ahead,
with
Nicolas.
our cases, sorry.
Please, Nicolas, go ahead. Yeah.
Yes. Well, no, again, not out of any data. We just we suspend medicine, and if there is nothing happening, then we monitor them until at least 6 months when the baby can go off breast milk and start feeding safely on formula feeds. But if the counts are beginning to misbehave, then we take the baby off breast milk. Then within 2 days, we can actually start once the baby is safely off breast milk, and then we restart the medication. That's our practice. But if they stay safe, then they can breastfeed as long as they are safe, like this lady has been.
And just to be clear, I don't recommend that women take TKIs and breastfeed, but I just wanted to be a bit provocative to say that the science of it may be more reassuring than they fear. But I agree with Danielle. I don't. I'm sometimes challenged with moms that don't want to wean the child, though, which is sometimes a challenge.
Thank
Thank
you.
you very much.
It is a tricky area, and thank you.
Thank you.
Thank you for this, bringing up this very important question also, Dr. Amma. And unfortunately, we are running out of time, and time is up for this meeting. And I would like, again, to thank you very, very much, especially our 4 experts we had, Professor Nicolas, Professor Mike, Dr. Amma, and Dr. Daniela. And also a special thanks also to our interpreters, Laurence and Alexandra. I switched in between to listen to French. It's an amazing job you're doing, doing the translation live and at the same time. So thank you very, very much for this. And of course, a big thank you to the whole audience and for joining us today for this discussion. And the ICMLF will send links to the recording of this session and a post-event package to you out in the next days. So yeah, wait for some more information on this. And don't forget, if you like to visit the ICMLF Foundation website, the Knowledge Center, where you find a lot of very, very valuable resources, and keep in touch with the news and updates about ICMLF. So that's it from me. Thank you very, very much. And in case of any questions, please reach out to Aline. Thanks to the 4 experts and to all the audience from all over the continent to joining us today. And I hope to see you soon in the next African ICMLF meeting. Thank you so much.